fractures of the spine, what essentially we are discussing about is a spinal cord injury. We know that all of us know that spinal cord injury is a very devastating injury that anybody can have because the treatment options are limited, and at the same time the outcome of these treatments are also not very great. For the undergraduate part, we will be discussing about thoracolumbar injuries, fractures in the thoracolumbar area, and cervical spine injuries. That's also an important part of the spinal cord injury, but this we will not be discussing today because that is not an important part in the undergraduate curriculum. Okay. Now, just to introduce the topic, we need to look at what we need to have a refreshing of the anatomy of the human vertebral column. So we know that how many vertebrae are there? There are 33 vertebrae in the human body. There are 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and the sacrum 5 vertebrae fused into one. Coccyx again there are 4 fused vertebrae. And at the same time, we should know that in between most of the vertebra there is what is known as an intervertebral disc. So when there are 33 vertebrae in the body, there are 23 intervertebral discs in the body. Okay, so some of these points which I have marked in red are important for multiple choice questions in the entrance. We should remember that in the adult, the spinal cord as such ends at the lower border of L1 vertebra. In child, it may be up to L3. So as we gain height from the child to the adult, what happens is there's a relative overgrowth of the vertebra when compared to the spinal cord. So in a child, it may be at the lower border of L3, but in an adult, it becomes at the lower border of L1. So till L1, the spinal cord there is spinal cord, and the spinal cord is comprised about the white matter and the gray matter. But after the L1, below the L1, the dura, inside the dura, there is no cord as such. It comprises of mainly the spinal roots, and these roots are known as the cauda equina or the horse's tail, cauda equina. So again, taking an implication further from that, we understand that up to L1, that is from C1 to L1, the spinal cord is involved. So when the spinal cord is involved, it is part of the upper motor neuron part. So the term that is used is a myelopathy. While below L1, when there is no cord to be involved, and this area is composed of only the spinal roots, and hence it is known as an LMN lesion or radiculopathy. So that the difference that you have to understand where the spinal cord will be involved, and so if you have a fracture of L5 vertebra, you will not have a UMN lesion because when the spinal cord when the dura is involved, there are only roots inside the dura at L5. So you cannot have a myelopathy in a patient with a fracture L5. Now again one more diagram to show. So this is each part is the vertebra, and in between the vertebra there is a jelly-like material which is known as the intervertebral disc. What is the function of the intervertebral disc? The intervertebral disc acts as a cushion or a shock absorber, because you know that all the 33 vertebrae are in different states of motion when we walk around, when we sit, when we bend forward, when we flex, etc. So you cannot have the vertebra bony structures rubbing against each other, which will be very painful. So in order to absorb the shock between the two vertebrae in varying degrees of movement, there is an intervertebral disc. An intervertebral disc is something, if you take the cross section here, the intervertebral disc, it comprises of a fibrous structure which is known as the annulus, fibrous, which controls the nucleus pulposus or the jelly-like material inside. And each vertebra are articulated with the next vertebra by means of the facet joints. So this much basic understanding of the anatomy that you should have. Okay, then if you take a cross section of the vertebral column, the cross section of the vertebral column, it will be like this. So this is the vertebra, this is the vertebral body as such. This is the facet joint, this is the lamina portion, this is the spinous process. And what is the main function of the vertebral column is to protect the vital spinal cord or the dura inside the vertebral, the spinal canal. So this is the spinal cord is actually surrounded by a little bit of epidural fat, and inside the inside the epidural fat it's a dura, and after the dura there is a subdural space. Then comes the arachnoid. After the arachnoid, or inner to the arachnoid contains a subarachnoid space, and then there is a pia mater. So the you know that spinal cord has got three coverings: dura, arachnoid, and the pia mater. And inside the pia mater you have the gray cells, the gray matter as well as the white matter. So this is basically what you have when you take a cross section of a vertebra. So the function of the vertebra is to protect the vital spinal cord. But you know that function, suppose this is fractured, this vertebral body is fractured, or there is every chance that this fractured piece of bone can hit onto the spinal cord and cause damage. So that is that is a basic idea that we should be having when you are talking about spinal cord injuries. Now, what are the questions that are usually asked from these topics? So we have to discuss about emergency management of a spinal cord injury victim. Second, they may ask you as a short note, what is a spinal shock? Then there are cord syndromes, which there are various cord syndromes which we'll go through in a short detail in few slides coming from now. Brown-Sea cord syndrome, central cord syndrome, and there is one more question that when you take all the question papers, you have a short note on burst fracture. So we will discuss each of these. So these are the ones that you need to understand. So what are the emergency things that you should do when a patient comes with a suspected spinal cord injury? Now I am going to talk about a clinical scenario. A 35-year-old man is brought to the emergency room with a history of fall from tree. On examination, patient is drowsy, and the examiner or the surgeon who sees the patient notes that he is unable to move his both lower limbs. So that is he is paraplegic. Upper limb power is normal. His BP is 90/60. Pulse rate is 50. So that is a classical way in which a patient with a spinal cord injury presents to you in the emergency department. So what are the things that we should do? The first and foremost thing that you see when you see a patient with suspected spinal cord injury, that doesn't mean that patient just need to come to the hospital. It may be at the site of injury, at the workplace or the farm or the field in which he has worked. The most important thing that you should teach and tell your colleagues and tell your paramedicals is that you should not further harm the patient. That is primum non care. The care should start at the site of injury, and assume all patients who are falling from height or being thrown out of a vehicle by a road traffic accident, or who has got a seatbelt injury from a road traffic accident, all assume that all these patients have a spinal cord injury. So anecdotally, I can tell you the most recent spinal cord vertebral fracture that has occurred to a very high profile person. You remember that the owner of Lulu Enterprises, Dr. M.M. Yusuf Ali, had a vertebral fracture when his helicopter landed in a marshy area accidentally. But the important thing, the thing was that he was taken to a hospital in sitting, and luckily he was so lucky that he did not develop a paraplegia from the injury. Ideally, he should have been taken in a spine board. He should have been immobilized in a spine board. The paramedics should have reached the spot. He should be made to wear a collar, so that will prevent any movement of the cervical spine. But instead, he was taken in a jeep or auto rickshaw to the hospital. Luckily for him, he did not develop further complication of the injury. So that is so important that we find that in various workplaces, the injured persons are brought to the hospital in auto rickshaw. They are bundled up in an auto rickshaw and brought to the casualty. At the time of injury, they may be moving all their limbs, but when the patient comes to the casualty in such a bundled up state, the patient may develop an irreversible injury to the spinal cord. So that is very important. So this is the spine board. So spine board, see everywhere, every portion of the patient is immobilized in a spine board, and you can see even if you do not have a collar, you can put two pillows like this on either side of the neck. Keep the head restrained so that patient will not move. And if you have a collar, this is known as a Philadelphia collar. This is a very important first aid measure that you can do whenever the patient comes to casualty or the any emergency setup. So, and you see that the surgeon is holding the neck to prevent any untoward motion of the head. And you should know what is known as a log rolling. Log rolling. So any patient suspected spinal cord injury, what you should not allow the patient to move on his or her own. You should have 4 persons. 4 persons should be there. 1 person at the head end of the patient, and he should be stabilizing the head and neck in line with the body. 1 person should be should be controlling the upper torso. 2 persons should be controlling the pelvis and the lower limb. So whatever sideways movement that you have to do should be done together, and then the patient should be immobilized in a spine board and taken to the nearby hospital. That is the importance of log rolling. Now, whenever a patient comes with the suspected spinal cord injury, we should not forget about the basics of resuscitation. Airway has to be checked, breathing has to be checked. Sometimes patient will be unconscious, there may be froth or vomitus in the mouth. This will all cause aspiration. We have to check this breathing and by means of a pulse oximeter. You have to check and establish, check the BP of the patient and establish a big cannula, not a small blue cannula or a pink cannula. You have to give a green cannula or a gray cannula. Very important. And so once airway, breathing and circulation are re-established, then is the time when we look for deformities like fractures, where you look for other fractures. When your patient falls from a height, you can have calcaneal fracture, you can have fractures around the knee, tibial condyle fractures, you can have fractures of the pelvis, and sometimes you can have abdominal injuries along with that. So these may be more life-threatening injuries than the spinal cord injury. So they should be given proper address. Then patient should be exposed, the clothes should be removed, and we should also examine his external genitalia, because a blood in the urethral meatus will suggest a grave pelvic injury, which if you are neglecting or missing, this may result in losing the patient due to hypovolemic shock. Now, if the patient is presenting early, one of the drugs that we can give in a patient with spinal cord injury is methylprednisolone. But you should remember that the dose that is prescribed for methylprednisolone is a very high dose. That is, you have to give a bolus dose of 30 milligram per kilogram. So, if a 50 kilogram person, that will come around 1.5 grams. Then this will be followed by a dose of 5.4 milligram per kilogram per hour. You can note down this. Dose 30 milligram per kilogram bolus followed by 5.4 milligram per kilogram per hour. So this is a very high dose of methylprednisolone that we have to give in these patients. Okay. Then, so these are the primary care management, because this is often asked one time for the university exam. This is the primary care management of a spinal cord injury. Now, another short note that is commonly asked both in orthopedics as well as medicine is, what is spinal shock? Now, when you see a patient after a spinal cord injury, when the patient comes to casualty, patient will be in a state that he is not able to move both his lower limbs or the upper limb, whatever the situation, and they will have temporary loss of motor, sensory, and all reflex activity below the level of spinal cord injury. So this is the condition which is known as a spinal shock. By spinal shock, we mean that the spinal cord is in a state of shock. It is in a state of shock due to the injury. So when you examine the patient, the limbs will be flaccid, that the motor system will be flaccid. There will be altered sensation of hyperesthesia, and you may have noticed that many of them will pass urine or feces on their own. So there will be incontinent bowel and bladder. So again, repeating, the limbs will be flaccid, hyperesthetic, and incontinent bowel and bladder. So this is the definition of it is a temporary loss of motor, sensory, and all reflex activity below the level of spinal cord injury. Now, the spinal shock, there are various phases of spinal shock. Initially, when the patient presents, this second part you just concentrate. Initially, when the patient presents, patient will be flat. I told you it's in a flaccid state. So there will be, all the reflexes will be absent. Then there is a second phase where certain reflexes will return. Which are the reflexes that are going to return? These are the cutaneous reflexes and the polysynaptic reflexes. For example, the initial reflex to return will be bulbocavernous reflex, anal wink reflex, or the cremaster reflex. Then there is also one more reflex which actually returns much earlier, which is known as a delayed plantar reflex, which is not important for the undergraduate, so I am not touching that part. So the initial reflex return, there is a stage of initial areflexia, totally areflexic. Then the certain reflexes start reappearing. So that is the term that these are the bulbocavernous reflex, the anal wing reflex, and the cremastic reflex. Then after that what happens is the reflex starts to become hyperreflexia. Hyperreflexia means you are eliciting the knee jerk, there will be the knee jerk will be 4+. Eliciting the angle jerk will be 3+. And further that will progress to more and more of hyperreflexia, which is manifested by increased tone of the muscles. So again repeating, the first phase is areflexia, which is flaccid, hypotonic. Second, you have the initial reflex return, which is where the cutaneous reflexes and the polysynaptic reflexes return. After that, the more deep tendon reflexes return, and the fourth stage will be the final hyperreflexia, where the patient gets spastic and hypertonicity. So these stages of spinal shock and the reasons for the spinal shock, if you are knowing, it will be good. Now, just time course and pattern of whatever I have told, again I am just repeating. So the bulbocavernous reflexes will return within a few days, 2 to 3 days. And the anal wing reflex, cremaster, all these will return within 2. These are the initial early reflexes to return. Now if we go to Babinski sign, this will return by 3 to 4 weeks or beyond that. So this deep tendon reflexy, deep tendon will take more time, may take 4 to 6 weeks. So this much amount of information you should have. So when do you say that the spinal shock has ended? So there is a definite pattern of end of spinal shock. So the cutaneous and polysynaptic reflexes will be the first to recover. So which are the cutaneous and polysynaptic reflexes that we are interested in? Bulbocavernous reflexes, cremastic reflex, and the anal wing. And also flexor reflexes recover earlier than the extensor reflex. That is why Babinski appears faster than the knee jerk. Okay. Then the more proximal the spinal cord injury. Suppose you have a cervical spinal cord injury, the return of the end of spinal shock is much earlier than compared to a thoracic spinal cord injury. So these points you should know. Now, what is the difference between a spinal shock and a neurogenic shock? Spinal shock, as already I've told you, there is an immediate temporary loss of power, sensation, and reflex below the level of injury. In a neurogenic shock, the same spinal cord injury, if the sympathetic nervous system is affected, what happens is the patient will have hypotension, and when you have hypotension, you expect the body to become tachycardic. That is what happens in a hypovolemic shock. When you lose a lot of blood from the body, there is a compensatory mechanism by which you get tachycardia. But this tachycardia is actually mediated by the sympathetic system. So when the sympathetic system is lost, the patient develops hypotension and bradycardia. So that is the difference between spinal shock and neurogenic shock. Spinal shock is due to the temporary loss, because the peripheral neurons have become unresponsive to the brain stimulus. While neurogenic shock is due to the loss of sympathetic system, autonomic pathway. So that is the difference that you should know. And what is the importance of spinal shock in a spinal cord injury victim? When you see that the patient is in spinal shock for a longer duration, suppose the patient has no reflexes returned for 2 weeks, that means that patient has got a very bad prognosis. So the delay in return of the reflexes is an important prognostic factor in predicting recovery from a spinal cord injury. So these points we have covered about spinal cord injury. Now, we should know what is a burst fracture. That is often asked for a short note. Now, I have in this figure, you can see one schematic diagram, a schematic representation of vertebra in the from the lateral. You're looking from the lateral side, and this figure you're looking from the top, which is known as an axial cut. Now, each vertebra is stacked over the other in a particular fashion. Now, a surgeon named Dennis, he divided this vertebra into 3 columns, and he made this study based upon the weight bearing capacity of each of these columns. So he has divided the vertebral body into an anterior 2/3 part, then which is known as the anterior column, then a middle part that is just anterior to the spinal canal. Here is the spinal canal, and this is the middle column. So the vertebral body itself has got 2 parts. The 2/3 part is the anterior column, the middle 1/3 part is known as the middle column, and rest is the rest of the vertebra, including starting from the pedicle, the facet joint, the lamina, the spinous process, and transverse process. All these together form what is known as a posterior column. So based on this concept, we can describe what is a burst fracture. Now, Dennis further divided any spinal trauma into 3. One is a major injury and minor injury. Minor injuries are the ones there are fractures of the transverse process, articular process, pars interarticularis, pedicles, spinous, all these posterior parts. These are known as minor injuries. Now, the major injuries are divided into 4 types. One is you call it as a compression fracture. Second is a burst fracture. Third is a seat belt type fracture, and sometimes the whole vertebra may be dislocated following a fracture, which is fracture dislocation. Of this, for undergraduate, you should know the difference between a compression fracture and a burst fracture. So this diagram, if you closely look, you can see that this is the normal vertebra. The second is a fracture. You can see that the vertebra has become a wedge shape. It looks like a wedge. Because of the on the other right side, I have drawn a burst fracture also, but that is not visible in the screen. But so a compression fracture essentially means only the anterior column is involved, while this is a typical one that is in osteoporosis. All ladies with osteoporosis, they become wedge-shaped, kyphotic due to the compression fracture. In burst fracture, it is the middle column that is involved, this portion, the middle column. So the difference between a compression fracture and a burst fracture is the involvement of 2 different columns. In compression fracture, it is the anterior column that is involved. In a burst fracture, it is the middle column that is involved. So we have looked at what is a burst fracture, what the Dennis column concept into 3: anterior column, middle column, posterior column. The Dennis classification into 4 types: compression fracture, burst fracture, seat belt type, fracture dislocation. Minor injuries, you know the rest of the thing: transverse process fracture, spinous process fracture, facet fracture, pedicle fracture, etc. So in compression fracture, it is the anterior column that is involved. In burst fracture, it is the middle column. So when a patient with a suspected fracture, you take an X-ray. How do you know that what is a burst fracture? You look at the interpedicular distance between the 2 pedicles on the fractured vertebra. See the upper one. See, this is the distance between the 2 pedicles. See, in a burst fracture, the interpedicular distance is widened. Interpedicular, that is the classical finding in an X-ray in a burst fracture. Then if you do a CT scan, you can see that the middle column is fractured, and this is known as retropulsion. You can see the vertebra of the fracture is lying, the fragment of the fracture is lying inside the spinal canal. So obviously we can know that the spinal cord will be compressed. So this is the typical CT scan of a burst fracture. And then if the further investigation that you have to do is a MRI, which will show you how much is the spinal cord discompressed. So these are the X-rays. X-ray will always be taken in 2 views: AP, lateral view. Then the CT scan will help to know that there is a retropulsed fragment. The MRI is used to look at the spinal cord. Then there is a stable burst fracture and unstable burst fracture. What is unstable burst fracture? When there is a compression beyond 30% of the site. Suppose this is a 100%. Suppose this is taken as 100%. When the vertebra has collapsed to more than 70%, that becomes unstable. And any burst fracture with a neurologic deficit. Sometimes the patient can escape without a neurologic deficit. So whenever there is a whenever there is a burst fracture with a neurological deficit, it is known as a unstable burst. So the difference between stable burst, unstable burst. Okay. So if the patient is having no neural deficit, we can treat them conservatively. And what we do is you support the spine by giving a brace. This brace that is commonly given is known as a Knight-Taylor brace. You should know these names: Knight-Taylor brace. Now, if the patient is more serious, or if he has more neurological injury, or if the burst fracture is severe, you have to decompress the fracture and support the fracture by giving the transpedicular fixation. These are particular screws that go through the pedicles into the vertebra, and you know that the height of the vertebra, the fractured vertebra here, is restored. So when you asked about burst fracture, you should mention about the middle column, the Dennis concept, the classification of the by the Dennis. You should distinguish between a compression fracture and the burst fracture, the complications of a burst fracture, what are the investigations: X-ray, CT scan, MRI. Then what is the stable burst fracture? What is the unstable burst fracture? Then what are the options of conservative management? What are the indications for operative management? The complications for all fractures of the spine, most important complication you should know is the presence of neurological deficit, depending upon the level in which the fracture occurs. Then sometimes many patients after fracture they develop chronic back pain. So this is this much thing I have covered now. Now one more topic that I have to cover is the incomplete the spinal cord syndromes, and this will be sometimes asked as a short note. Okay. So what are the spinal cord syndromes? Complete spinal cord syndrome and incomplete. Because complete means there is nothing nothing to discuss much, because it is a complete paraplegia or quadriplegia. So there is nothing much to discuss about complete spinal cord syndrome. But incomplete spinal cord syndrome, there are few varieties that you should know. So the common incomplete spinal cord syndromes are the Brown-Sequard syndrome, central cord syndrome, anterior cord syndrome, posterior cord syndrome, conus medullaris, and the CAUDA equina syndrome. Of this, most important for undergraduate exam part as the Brown-Sequard syndrome, central cord syndrome, and the CAUDA equina syndrome. Sometimes CAUDA equina syndrome is asked for 3-mark question in the exam. Now let us come to the Brown-Sequard syndrome. I want all of your attention to this diagram here. So you know that in spinal cord there are various tracts. There is a central canal. And surrounding it there are various tracts. We know that posterior part of the spinal cord is mainly concerned with what? It is concerned with fine sensations, which is known as the posterior column. It is mainly concerned with the vibration. It is concerned with proprioception. It is concerned with the fine touch. With the positioning sense. Then we have the lateral corticospinal tract, otherwise it is known as the pyramidal tract, which is controlling the motor part of the body. Then we have the spinothalamic tract, there are two spinothalamic tracts. There are anterior spinothalamic tract and the lateral spinothalamic tract. The lateral spinothalamic tract, which is the sensation that is carried through it, it is the pain and temperature, while the anterior spinothalamic tract carries the crude touch part. So each of this you should remember. The posterior column consists of position, vibration sense, the fine some amount of fine touch. Then the lateral spinothalamic tract and the anterior spinothalamic tract are there. The lateral spinothalamic tract, the pain and temperature is being carried. Anterior spinothalamic tract carries the crude touch, and the corticospinal tract is important for the motor part. So in Brown-Sequard syndrome, what is happening is half of the cord becomes involved. Half, that is like a hemisection of the cord. Okay. So when a hemisection of the cord what happens is, so you know on the side of the lesion, suppose the lesion is on the left side, patient will lose all the posterior column sensations. They will lose loss of position, vibration. Then the motor loss will be on the same side, and what happens is pain and temperature, because that is crossing from the one side to the other, that will also get lost from the opposite side. So in a Brown-Sequard syndrome, the things that are lost on the same side are posterior column sensations like loss of position and vibration, the weakness on the same side, but loss of pain and temperature from the opposite side. So that you should know. That is the essential feature of a Brown Sequard syndrome. It is a hemisection of the spinal cord. It can occur in a penetrating trauma, so usually it's knife injury, penetrating trauma. Sometimes a penetrating tumor can cause a Brown Sequard syndrome. Sometimes a extramedullary lesion can grow from the outside of the spinal cord and press on to the one half of the spinal cord. So again, to repeating the clinical features, we can note down this very important topic: sensory, ipsilateral loss of proprioception due to posterior column involvement; opposite side, contralateral, loss of pain and temperature due to involvement of the lateral spinothalamic tract. Motor, the same side, UMN lesion, because if it is in the cervical spinal canal or the thoracic spinal, you get a UMN lesion. So there will be spastic weakness due to the involvement of the pyramidal tract. And at the level of the lesion, you get LMN signs. At the level of the lesion, you get the LMN signs. So this is again what is happening. So hemisection, level of injury, suppose it's at the level of injury here, loss of movement on the same side as the cord damage, loss of pain and temperature and sensation on the opposite side. So you should be thorough about this when somebody asks you. Then there is the central cord syndrome. Now, central cord syndrome, you know that there is a central canal here in the center part, and there is the gray matter which actually surrounds the central cord. Okay, this. So when something is occurring here and the central canal is expanding due to some problem, there will be damage to the gray matter nerve cells and the crossings, because even the lateral spinothalamic tract, you know, that will be crossing very close to the spinal, the central canal. So a classical example is a syringomalia. When you central cord syringomalia, then trauma. Sometimes in patients with cervical spondylosis, you can get hyperextension injuries to the neck, where where there will be edema around the central canal. So the features will be sensory, dissociated sensory loss, loss of pain and temperature sense of the shoulders, lower neck, upper trunk, in contrast to, because the light touch, joint position, vibration are part of the posterior column which is far away. So that will be preserved. Okay. Then the hallmark of a central cord syndrome is arm weakness is much more than the leg weakness. That is because the cervical fibers are more closer to the central canal. So the upper limb fibers are more closer to the central canal. So you get arm weakness out of proportion to leg weakness in a central cord syndrome. That should be borne in your mind. So this is the typical. So you know the central canal. This is expanding. So when it expands, it will gradually be involving the the motor tract, the crossing or fibers in the lateral spinothalamic tract. Then what is the anterior spinal syndrome? Anterior spinal syndrome. See, you know that the anterior spinal artery supplies the anterior 2/3 of the spinal cord. Posterior 1/3 is supplied by the posterior spinal artery. So when something happens, suppose you get a occlusion in the anterior spinal artery, what happens is the anterior 2/3 of the spinal cord becomes ischemic. So all these tracts that are involved are there in the anterior part. They get involved, while the posterior part of the spinal cord, which is the dorsal column, they are spared. So patients develop weakness, loss of pain, and loss of all other sensations excepting joint sense, position sense, and vibration sense. That is the typical. Usually you get in ischemic injury to the anterior spinal artery. See, there is loss of movement, pain and temperature, but patient will be still able to feel position, vibration and touch in an anterior spinal artery syndrome or the anterior cord syndrome. Now, the most important one, that is the CAUDA equina syndrome and the conus medullaris. So in my initial slide, I suggested that the spinal cord ends at L1. So when you come to the take the anatomy of the spinal cord, at the L1, the spinal cord becomes slightly bulbous, and that portion is known as the conus medullaris. After that, all the CAUDA equina roots start, and they come right up to the sacral foramen, and they exit at various levels. In the conus part of the spinal cord, the portions that are the spinal segments that are represented are the lower sacral segments. Maybe L4, L5, S1, 2, 3, 4 segments. So in a CAUDA equina, the typical presentation will be a patient with bilateral by patient with a gradual presentation, gradual weakness, and usually one side is more affected than the other, unilateral, or and the other side is one side will be asymmetrical involvement. See, this is important. This asymmetrical involvement, and then you can see it is LMN. It is never UMN because it contains only the roots. So the CAUDA equina syndrome is always LMN. That means the deep tendon reflexes are going to be diminished, and most often because the roots are involved, patient has severe pain, radicular pain, a pain along the root. So when you take sensory aspect, there will be numbness which is asymmetrical. There will be severe radicular pain. The motor part, when you look at the motor weakness, will be there in both lower limbs, but they are going to be asymmetrical weakness. The reflex part, when we see there will be element reflexes. That is means the reflexes are absent or diminished. Then the bowel and bladder, they present later. And the most common that they have is the urinary retention. So again, whenever you get the symptom, think about what happens to the motor, what happens to the sensory, what happens to the reflexes, what happens to the autonomic system. This is the way you should think about in any syndrome, any CAUDA syndrome. So in a CAUDA equina syndrome, it is if you look at motor, it is a unilateral or commonly bilateral, but which is asymmetric weakness. That is important. Asymmetric weakness, the progression of weakness is gradual. Then if you look at the sensory, the numbness will be there, but again the numbness of paresthesia is going to be asymmetrical. Then when you look at the reflexes, the element type of reflexes are going to be there, either they are absent or they are diminished. When you look at the autonomic system, the bladder involvement is late. Most often the bladder involvement is urinary retention. But when we come to Conus syndrome, so Conus is the last part of the human part, last part of the spinal cord as such. So in a Conus lesion, it will be sudden and bilateral. Weakness will not be that profound because it is the sacral segments that are going to involve. So the weakness will be more from the angle. Below the angle, it is usually symmetrical with respect to the numbness, and the reflexes are diminished at that level, but brisk below the level. So knee jerk will be diminished, but angle jerk will be exaggerated. And the involvement of the autonomic system will be early. Both urinary, bowel incontinence, impotence is frequent. So that is how you distinguish between a conus medullaris syndrome and a CAUDA equina syndrome. So conus medullaris, sudden, bilateral, symmetrical weakness. Radicular pain, sensory pain will be less. Numbness will be symmetrical. The deep tendon reflex will be diminished at the level, but brisk below the level. Sphincter function, the autonomic function, it will be present early. Bowel and bladder is incontinent. Impotence is more common. That is how you distinguish between a conus medullaris and a CAUDA equina syndrome. Practically, there will be a lot of overlap. Sometimes the patient has got a conus and CAUDA equina syndrome together. A little bit more discussion on the CAUDA equina syndrome. The most common cause of a CAUDA equina syndrome is a large extruded central intervertebral disc herniation at L4, L5 level. So also that can be present in tumors, that can be present in fractures of the L4 vertebra, that can be present in infection or abscess inside the spinal cord. So you should mention all these clauses. Why we are discussing this CAUDA equina or conus medullaris as a separate entity? Because these are surgical emergencies. So you need to take up these patients, work up these patients faster. You have to find out an essential cause. What is a conversive lesion there? And you have to take these patients for most of the time taken for emergency decompression. So I have completed the various cord syndromes. Just summing up the cord syndromes: round C cord, central cord, anterior cord syndrome, posterior cord syndrome. Posterior cord syndromes are all very rare. And posterior cord syndrome essentially is a medical condition that is usually you get in tabes dorsalis or the subacute combined degeneration of spinal cord. So otherwise, that is not an orthopedic condition. Then you have CAUDA equina syndrome. You can have conus medullaris syndrome. So I am completing this topic. I've gone through the most important parts of this topic. You can read the textbook, because if you read today itself, you will register many of these points. and many of them have, what I've discussed, have got overlap between neurology, the medical part. So it should be a revision for you also. So anybody